We have a very good crowd assembled here today for our webinar with Dr. Kinderlehrer. Moderating today's discussion is Dr. Craig Shimasaki. Dr. Shimasaki is the co-founder and CEO of Molecular Labs, a neurobiology, excuse me, a little frog in my throat, a neuroimmunology, excuse me, precision medicine company focused on identifying the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech and has been in the biotechnology industry for over 35 years. As a scientist, his work spans all stages of research and development, from bench to bedside. His research includes epitope mapping for an HIV vaccine, genetic breast cancer risk detection, prediction biomarkers, a rapid influenza diagnostic and therapeutics for infectious diseases, neuropsychiatric disorders, and noise-induced hearing loss. As a business person, he co-founded multiple companies and led multiple products through the FDA approval process and is co-inventor on multiple patents. Dr. Shimasaki Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University's Kellogg School of Business. He is an adjunct professor at the University of Oklahoma Price School of Business and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. Our speaker today is Dr. Daniel A. Kinderlehrer, MD. Dr. Kinderlehrer is a nationally recognized physician with expertise in the fields of nutrition, allergy, environmental medicine, Lyme disease, and the healing of mind, body, spirit as a unified whole. Dr. Kinderlehrer co-founded the New England Center for Holistic Medicine in Newbury, Massachusetts, and has taught extensively, including practitioner training courses at the Omega Institute, the National Institutes of Behavioral Medicine, the American Academy of Environmental Medicine, and the International Lyme and Associated Diseases Society. He created and organized the Lyme Fundamentals course, which is presented annually at the International Lyme and Associated Diseases Society conferences. He is the author of several articles in medical journals, the Lyme Times and Psychology Today. His integrated medical practice in Denver, Colorado, focuses on the diagnosis and treatment of tick-borne illness. Dr. Kinderlehrer is the author of Recovery from Lyme Disease, the Integrative Medicine Guide to the Diagnosis and Treatment of Tick-Borne Illness, which was released in March of 2021. So without further delay, Dr. Shimasaki, I'll turn this over to you, and thank you.
Thank you, Amy, and welcome everybody to this second part of the webinar. So what I want to share with you is just a little bit about, can infections really trigger neuropsychiatric disorders? And that's really the question that often occurs in areas and groups that may not have ever heard about immune-mediated neuropsychiatric disorders. So I share with you this JAMA Psychiatry article published in March of 2019, in which this group followed over 1 million individuals in Denmark from birth to age 18. What they identified is that if a patient or an individual was hospitalized for a severe infection, that they found that the risk of developing some type of mental disorder increased by more than 80%. And these diagnoses include schizophrenia, autism, obsessive compulsive disorders, ADD, ADHD, personality disorders, oppositional defiant disorders, and many, many more. In an accompanying editorial, they asked, how could exposures to infections affect the brain mechanistically to give rise to mental disorders? They replied that circulating autoantibodies that enter the brain via compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation, and the mechanism has been proposed in PANDAS and other mental disorders. And this is really what we're here to talk about today, a little bit about the biology and a lot about the clinical manifestation, as Dr. Kinderlehrer will share in this part too. Just to remind us that worldwide, there are over 800 million individuals who do suffer from various types of neurologic, psychiatric, and behavioral disorders, all with differing types of diagnoses. But currently, all of these are diagnosed entirely by clinical presentation and not biology. And unfortunately, these are labels that patients get, and typically they are treated symptomatically. There are studies and reports that approximately 30% or so of many of these patients who are on psychiatric meds are what we'll call treatment resistant. And it is also important to understand what's the etiology of those and how can these be helped. Well, interestingly, that infection-triggered autoimmune neuropsychiatric disorders are not new. If we look back in history, you can look at Sydenham chorea, or what was used to be called St. Vitus's dance. And that was these abnormal type of movements, particularly in children, which also was accompanied by loss of fine motor control and loss of emotional control. Even in the 1600s, when Sir Thomas Sydenham described what he called chorea minor, and then in the 1800s, Sir William Osler described these bizarre and percipitive behaviors of these children with chorea minor, including OCD, and those that were later termed Sydenham chorea. Well, as we know today that the causative agent is group A streptococci, in which these autoantibodies that are triggered by group A strep began attacking parts of the brain. But Sydenham chorea is also the neurologic manifestation of acute rheumatic fever, which we also know that it is a group A streptococcal infection that triggers autoantibodies that are attacking parts of the heart, particularly the heart valve, and also particularly different types of proteins contained within them. Interestingly, if you look at the evolution and the identification of other neuronal autoantibodies, you can see many of them here. Some that you might be familiar with was the NMDAR receptor encephalitis. You can see aquaporin 4, the glutamic acid one, GAD65, and it continues to be evolving as more and more conditions are described and identified with anti-neuronal antibodies. What we here at Molecular do and continue to research and provide testing for are 5 particular anti-neuronal antibodies and a cell stimulatory assay, which we call the CAM kinase, that have been clinically shown to have associated with certain neuropsychiatric behaviors and symptoms. The first one is antibodies directed against anti-dopamine D1 in the brain, which is heavily concentrated, these dopaminergic receptors, particularly D1. When they're positive, we see that these are associated with various types of psychiatric symptoms. When there is autoantibodies directed against the dopamine D2 receptor, we typically can see that there's an associated movement disorder. They may have some type of choreiform movement or things that really may even consist of help with the diagnosis of ADHD due to the inability to hold still. The third target that we do see is targets or antibodies against lysoganglioside GM1, and that is simply the myelin sheath around the nerves. We refer to this as the tick cluster because we do see complaints of connective tissue and joint pain. One that is also seen commonly, and that is autoantibodies against tubulin, which is intracellular structure in most cells, highly concentrated in the brain. In fact, what we see associated with that is frequently what people may think of as brain fog or other obsessions and compulsions, phobias, and things like that. And then finally, a fifth target, which we often see in patients that have associated various types of sympathetic nervous system activation. So the CAM kinase, which we won't go in through today, is actually a kinase activity that occurs and it helps neuroplasticity in the brain. But when these are constitutively on or triggered to be activated, we see patients that show symptoms of fight or flight behavior, various things like separation anxiety, and even mydriasis with dilated pupils. So these are helpful clues and helpful targets as you monitor and identify the underlying cause of patient symptoms. So how does this occur biologically? We all know that we are exposed to various infectious agents. We also know that our body, through its adaptive immune system, will eventually produce antibodies directed against certain targets in the immune system or against the particular infection via the adaptive immune system. In certain patients, and this is a susceptibility component, is that some patients in which they generate antibodies against certain receptors or certain parts which we call antigenic determinants of these particular infectious organisms. They are common to targets in the brain, and hence these antibodies get produced that have cross-reactivity, and we see that happening with these targets that I mentioned previously that do result in these neuropsychiatric symptoms. And patients typically will be placed on these attempting to reduce the symptoms, but in these patients, they tend to be treatment resistant, and also, in many cases, standard dosages of these can also and typically do not help the patient, and often we see these actually worsen. The advent of COVID has helped us to understand biologically and medically that other infections can do this too. COVID has not been restricted to just neuropsychiatric symptoms, but also various types of other organ systems components, which we affectionately, I guess, refer to as long COVID. As Dr. Kinderlehrer will talk about, there are various types of infections that are frequently associated with these encephalopathies. You can see the list here, and typically it's because of common epitopes. So just really briefly, an epitope is really a component in which an antibody is recognized, as you can see here. And they're just a string of protein letter alphabets in which the immune system then develops B cells that have memory. But what happens when that particular epitope is actually identical in sequence to a particular epitope, let's say on a neuron? Once those antibodies are developed, they will naturally identify and cross-react with anything that looks like it. And that's what we call molecular mimicry. And so there is, in which will be talked about a bit, a PANDAS, and specifically what is known a little bit more about basal ganglia. It has certain cognitive functions, emotional functions, procedural learning. But if you look at the PANS criteria, you can identify that some of these criteria fit very nicely with the targets in the basal ganglia, such as anxiety and emotional control, emotional functions, the behavioral and developmental regression on cognitive functions, sensory and motor abnormalities with the voluntary motor control, and these others, which do correlate to interference with normal biological function of the basal ganglia. And there's publications that have been shown that these antibodies do target the basal ganglia. What we really are looking to do is the goal of precision medicine, to identify the root of a disorder and then treat that root, which is really what we intend to do with the identification of these anti-neuronal antibodies, such that patients can be responsive to specific types, anti-infective, anti-inflammatory, and immune modulatory treatments. Part of our research continues to grow in being able to predict through AI and treatment algorithms that might help in the sense of predicting treatment efficacy. And so finally, just leaving you with this nomenclature, which can be confusing, PANDAS and PANS, or in this case, PANDAS, we see are infectious triggers, but there are other microbes and even non-infectious triggers, which is where the term PANS came from. So it's agnostic to the organism. PANDAS and PANS, though, refer to pediatric, whereas other nomenclature has been identified or at least addressed, such as ANDL, often referring to adult neurologic disorder from Lyme, and things that we see and hear now in literature called autoimmune encephalopathy, secondary to infections, basal ganglion encephalitis, which basically we're going to be talking about an immune dysfunction that results in neuropsychiatric and behavioral symptoms secondary to infection. So in conclusion, what we want to do is emphasize that autoimmune encephalopathy of infectious etiology can be a part of many different commonly identified disorders, but until you understand what the root is, it's very difficult to treat and with effective treatment, because treating symptoms in these cases don't seem to be very effective. And lastly, if molecular mimicry in practical terms, as you can see here, basically misidentification. This one says, "You don't get lunch. Mom thought I was you and fed me twice." And so with that, I'm going to turn this over to Dr. Kinderlehrer, who's going to share with you the second part of microbes and mental illness, and much of the therapy and how he has identified and treated these patients and got them well. So Dr. Kinderlehrer, I'm going to turn this over to you.
So let's start. Historical context. It was in 1994 that Susan Sweeto at the National Institute of Mental Health described some children who developed OCD and some tic disorders following a strep infection. And then she followed that up in 1998 by describing a series of 50 children who developed similar problems. And she had criteria. She just said these were all in prepubertal children who were fine. They were normal. And then they got a strep infection, fell off a cliff. And she coined the term, really, PANDAS. So pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. Great, good name. In 2013, at the NIH, there was the first PANS consensus conference. Now, that's when PANDAS was expanded to PANS. And the main reason was because they found that, first of all, it was not only in prepubertal children. So the PANS criteria basically increased that to youth up to 18 years old. And the other is it's not limited to strep. There are a whole bunch of issues associated with multiple pathogens. So we're going to be talking about PANS, and I just want to say this is a big problem, and we're seeing more and more and more of this. Why? Well, we got three epidemics that are converging in this diagnosis. So first of all, we got Lyme disease and tick-borne infections. It's now been described that 15% of the world's population have or have had Lyme disease. The world, we're talking not just the United States. Autoimmune conditions. Well, there's been a survey, for example, in Great Britain. As you know, they have the National Health Service, and they can do surveys pretty easily. 10% of 22 million people diagnosed with an immune illness. Okay, that's huge. And mental illness in children and adolescents, I'm sure you're all aware of how this is growing. I mean, when I was growing up, which was a really long time ago, we just didn't see the problems that kids are having now. The WHO in 2019, notably, this is pre-pandemic, 15% of youth globally diagnosed with a mental health disorder. This really is a convergence. People, including kids, are getting sicker, and immune mediated disorders seem to be a large piece of it. I think there's multiple factors for that. In fact, the last chapter of my book, I talk about the factors that have accumulated over the past century and particularly regenerate with epigenetics, so that each generation, basically gathers the traumas of the previous generations. Okay, I'm going to move on and talk about autoimmune encephalitis versus PANDAS. So it's not like there's one against the other. It's actually that autoimmune encephalitis subsumes PANDAS. So we can talk about autoimmune encephalitis, which Craig has done a good job describing. And the way I describe this to parents who are new to this is I start with rheumatic fever, and I say, okay, rheumatic fevers, you get a strep infection, you get a strep throat, but the antibodies get confused, just as Craig described with molecular mimicry, and they attack the heart valves because there's this epitopes that are similar. So you have an autoimmune illness and you have an infectious etiology. It's both. But with PANDAS, what we're talking about is antibodies that attack the brain. So that seems to work. That seems to be an explanation that really helps parents understand what we're talking about. So PANDAS turns out has a case definition. It's a subset of autoimmune encephalitis that fits these specific criteria. The abrupt onset of OCD and or eating disorder, really eating restriction, in a child or adolescent, again, up to 18 years old. No known neurologic disorder to account for the symptoms. They don't have a seizure disorder. They didn't just have head trauma, et cetera. And at least two of the following: anxiety and panic attacks, mood swings or depression, irritability, aggression, and rage, behavioral or developmental regression. Remember, we're talking about kids. Somehow they start to go back in maturity. Deterioration in school performance, often some real significant cognitive problems, motor or sensory abnormalities, and other somatic signs and symptoms like bedwetting and pain syndromes. Okay, this I think is really an important slide. Common features of PANDAS. So I just mentioned at least a handful of these, but some of these are going to be a little more subtle. Handwriting deterioration. I want to point out that psychosis can be really severe, particularly in these kids with eating disorders. But, we see kids who are hallucinating and really not connected with reality, at least at times. The irritability, anger, and violence can be bad. I mean, just 2 days ago, the biggest issue with this kid who's somewhere around 11 years old is violence towards his siblings. I mean, it's dangerous. And then the other ones you can see, again, Craig has mentioned a bunch of them, but I'm going to come back to this whole case definition of PANDAS because I think it's somewhat limited. Okay, what are the microbes? Well, we're going to find more microbes, but I want to point out that there's a lot of viruses that have been implicated. There's 2 microbes here that are tick-borne, can be tick-borne. You can get them other ways, and that's Bartonella and Mycoplasma. Strep is the obvious one, but SARS-CoV-2, I think this is a big one, actually. Causes a lot of neuroinflammation, and Craig referred to long COVID. And we're seeing a lot of neuropsychiatric problems with long COVID. We see a lot of dysautonomia with long COVID. We see a lot of systemic inflammation with long COVID. I suspect that the autoimmune inflammation with long COVID is not dissimilar to what we see with tick-borne illness. Okay, Cunningham Panel. Well, Craig's already talked about it, but this is a way that we can scientifically document what may be happening here. And so there you have it. There's the antineuronal antibodies and the CAMK2 activity. And just pointing out that CAMK2 modulates dopamine synthesis and NMDA receptor activity. No surprise that this can cause neuropsych issues. So this is a study that Craig was the primary author of. Basically, they had over 200 patients that they screened, and they needed to find 58 patients who met the criteria to fit into PANS or PANDAS. And then they studied them. They did a Cunningham panel before treatment and after treatment. Out of those 58, 34 improved or resolved, 24 did not improve or they worsened, and there was a strong positive correlation between the neuropsychiatric symptoms and anti-neuronal antibodies and activation of CAMK2 enzyme. Cunningham Panel results correlated with patients' neuropsychiatric symptoms, very high sensitivity and specificity, as you can see. So, when in doubt, this Cunningham Panel can be really important particularly when you're trying to convince your colleagues that this kid has an autoimmune encephalitis. Okay, so I'm going to start with some case histories here, describe what we're talking about. This 17-year-old male, that 17 when I encountered this male, when his parents asked for a consultation. When he was 2 years old, he had a febrile syndrome. He was tired, nothing else clinically, but his laboratory showed pretty low platelets, and he recovered without treatment. But between 2 and 4 years old, he became what his mother called a scary child, violent tantrums, not just, terrible twos, but really violent. Okay, I mention this because I think it's more likely than not that he had a Bartonella infection when he was 2 years old. And guess what? Bartonella causes over a dozen. I can mention over a dozen autoimmune conditions that are triggered by Bartonella, and one of them is ITP, idiopathic thrombocytopenic purpura, low platelets. And then guess what? Then he had probably an autoimmune encephalitis triggered by Bartonella with these violent tantrums. And then his immune system sort of evened out, and he was okay until he was 12 years old. He's at summer camp in Oregon, suddenly becomes ill with a fever of 104 degrees. They take him home, and then things go way south. Okay, severe OCD. Let me tell you how severe this was. He was in the shower for 5 hours, and they had to get the police to get him out of the shower. Anxiety, rage, violent, really some really bizarre behavior, actually. He was defecating in different rooms of the house. He wouldn't let people touch him. It was bizarre. And then anorexia. He wasn't eating, and he had this psychotic, delusional concept that he needed not to eat, he needed to lose weight to cure his severe anxiety, etc. This kid, by the way, wanted to go to the Olympics. He was a snowboarder, and they moved to Utah to be in Park City or someplace where people train for this. And then, things went terribly south. Okay, so that's how Thomas presented to me. He was 17 years old when I saw him, and he weighed 70 pounds. And when we worked him up, we did strep antibodies were negative. We did thyroid antibodies, they were positive. A GAD65 antibody, this is another anti-neuronal antibody that Craig mentioned. This is a really important one for you folks to know about if you don't, because it's a ticket to IVIG. An elevated GAD65, you're approved for IVIG. Okay, he had some mild elevations to Mycoplasma pneumonia, IgM and IgG. I'm going to come back to that one. Lyme immunoblot, IgM band 41, not specific for Lyme. It's sensitive, but not specific. But IgG band 39 is is actually very specific for Lyme. When I say very, we're talking about over 90% specific. Okay, so what we can say is, oh, this kid has had a tick bite and he had a high fever. What does that tell us? This high fever in the presence of a tick bite in an acute situation, almost always that's Babesia. So what do we find? Well, two things. One is that he had Bartonella. You can see that he had a positive IgG and a positive FISH test, which is an RNA test that's quite specific, like a PCR. And of course, he did have positive Babesia antibodies, Babesia duncani, which is interesting because he was in Oregon when he got this, and it was in the Pacific Northwest that this particular species of Babesia was first found. And then he had a Cunningham panel. Here you can see the abnormals of the Cunningham panel. And there it is, significant elevation in anti-tubulin antibodies and also in the CAMK2 activity. Okay, so what are his diagnoses? Well, he's got Lyme, he's got Bartonella, he's got Babesia. By the way, most of my patients have this trifecta. Does he have mycoplasma? Well, I'm not sure. He had low-grade elevation in antibodies. The IgG antibody, most of us have some antibodies to Mycoplasma pneumonia in the IgG category. Now, the IgM could be significant, but also there's a lot of cross-reactivity. Basically, I'm not sure if he had mycoplasma or not. Mast cell activation syndrome, his mother described severe dermatographia. For those of you who don't know, you scratch the skin, it leaves a red line, sometimes white, sometimes both. That's an indication of excess histamine. And I can tell you that most of these kids have some degree of mast cell activation syndrome. We did test him for mold toxins, and that was elevated. And this kid, basically, he was a poster child for PANDAS. I mean, he checked off all the boxes when you look at his presentation, the abrupt onset of OCD followed by other mood and behavioral symptoms, and particularly an eating disorder. And but here's the terrible thing. He gets diagnosed with PANDAS pretty quickly, right? They live in Silicon Valley at that point. They go to Stanford. Stanford, they actually believe in PANDAS. I don't necessarily agree with the way they treat it. Basically, they gave him steroids. And after a course of prednisone, it was for about 2 weeks, his OCD got much better, but then 2 weeks later, it came back. They gave him a second course. Nothing happened, and then they dismissed him. So here's this kid who's sick as a dog. That was it. And so even though he had a PANDAS diagnosis from the onset, it was about 4 years later before the tick-borne infections were diagnosed, basically when they asked me for a consultation. So let me go back to Thomas for a second. This is really upsetting. So Thomas, when I met him and met his parents, he was in an eating disorder unit, an inpatient unit in Utah, okay? And he had a couple doctors, a family doctor and an eating disorder specialist. We would get together every week. And basically, I educated them about autoimmune encephalitis. They were all aboard, but could not get antibiotics into him while he was in the inpatient unit because the infectious disease people would not okay it. And then so they bring him home. So at that point, we do get him on some intravenous antibiotics, but this kid is so psychotic. His weight dropped from 75 at that point to in the 60s. He was sabotaging his caloric intake. Then he ran away from home. I mean, it was pretty crazy stuff. And they had to readmit him. And again, he's off antibiotics. Basically, that's where we're at with this kid. And I personally only know of one inpatient eating disorder unit that will give antibiotics. It's Waltham Behavioral Clinic in Massachusetts. And there may be others, but I don't know. The parents have really tried to get him admitted different places. Okay. So that's a very sad story. Thomas is still suffering, as is the entire family. Okay, so this one is a happier outcome. So Lindy, 10 years old, so she was like in third grade, I think. She had the sudden onset of feet on fire, but then other symptoms came on pretty quickly. OCD, intrusive thoughts, sound sensitivity, paresthesias, pruritus, that's itching and rashes, anxiety, phobias, muscle aches, poor sleep, then panic attacks, irritability, cognitive decline, headaches, hallucinations. And again, she was in Maryland and West Virginia at the time. I have a lot of patients who got tick-borne infections in Maryland. And she was diagnosed with PANDAS pretty quickly. And she was given some different antibiotics, amoxicillin, ceftonor, azithromycin. Didn't make her worse, didn't make her better. And then the doctor put her on IVIG. And when IVIG is used to treat an autoimmune illness, the dose is 2 grams per kilogram. But I can tell you it's not a good idea to start at that dose. She immediately got worse. All the symptoms got worse. We can debate what the pathophysiology of that is, but it clearly increased the inflammation. And so I say this to you folks, because if you can get IVIG, it's great, but I would start on a lower dose and work up to the 2 grams per kilogram. Okay, so what happened? Well, she got worse. The joint pains and leg pains got worse, and then she refuses to walk. She's in bed. That's it. And we're in a wheelchair. The abdominal pains and nausea get worse, and then she refuses to eat. Nothing. Zero. Then they put a nasogastric tube in, but obviously that's not a long-term solution, so they put in a J tube. That turned out to cause more abdominal pain, so then she's put on hyperalimentation. So these are happening, boom, boom, boom. Laboratory. Well, she also had some elevation in thyroid antibodies. So, something to look for in these kids is autoimmune thyroiditis. And I mentioned that Bartonella has been implicated in a lot of autoimmune conditions, also autoimmune thyroiditis. Okay, her histamine level was okay, but I'm sure she had mast cell activation, as you'll see. She had multiple ASO titers before I saw her. They were all negative. She had significant elevations in mycoplasma antibodies, as you can see. What else? Well, she had a positive Lyme ELISA test. She had what I would consider a positive Lyme immunoblot, IgM. Band23 is basically an antibody to outer surface protein C, and like the 39 band, it is quite specific, not 100%, but probably over 90%. Bartonella immunoblot IgM was positive. Babesia Babesia duncani IgM very positive, and a Babesia fish was positive. Okay, so I'm looking at her and I'm seeing at least 4 infections. I'm seeing Lyme, Babesia, Bartonella, and mycoplasma. She had a lumbar puncture. CFS is normal. This is also important because I'm used to seeing normal cerebrospinal fluid in these kids with autoimmune encephalitis, not like direct invasion by a microbe encephalitis. Okay, she had mycotoxin levels that were elevated. And, she was so sick, I mean, in terms of her functionality, in terms of her mood, we did more testing and we did a methylation profile. I personally find that looking at intermediates is really important. So I want to point something out because I see this pattern in most of my patients who have autoimmune encephalitis. She had two mutations at the MTHFR gene. So the A1298C was homozygous. And you'd expect that to cause an elevated homocysteine, right? No. So that combination of one or two mutations at MTHFR, but low homocysteine, that's what I'm seeing. So when we did a methylation profile looking at intermediates, she had significantly low levels of SAMe, methionine, glutathione. I'm going to show you a methylation map, okay? And do I have, yeah, here we are. Two mutations here, right? And that's going to convert folate to its active form. And that's going to be that's going to reduce activity around 70%. So this cycle is going to be going pretty slow. That means this cycle is going to be going really slow. That means homocysteine should be elevated, but it's not. Why? Because there are mutations at the CBS gene. And some of those mutations cause upregulation. So what you have is acceleration of the transsulfuration pathway. And without going into specifics, that is typically associated with low glutathione. So now you have low homocysteine, low glutathione, and homocysteines not get converted to methionine and SAMe. These are really, really important. And so this combination, low methionine, low SAMe, low glutathione, that's a really challenging profile. I have a significant section of that in my book. Here is Lindy's Cunningham panel, and you can see, significant antibodies to the anti-dopamine receptor D1, also anti-tubulin, and sort of borderline slightly elevated CAMK2 activity. Okay, so what's her diagnosis? Well, she clearly has these 4 infections that we've already talked about. She has the methylation mutation. She has autoimmune thyroiditis. She has some mycotoxin issues. She has mast cell activation, and she has PANDAS. I think she meets those criteria. The onset of the OCD, et cetera, was fairly abrupt, even though it started with feet on fire, which is a neuropathic syndrome, of course. Okay, so what do we do? One thing to be very clear about is we do one thing at a time. You don't throw a bunch of things at these kids, or adults for that matter, because you never know if they're going to tolerate something or not tolerate something, even if it's pretty benign, like an antihistamine. You really just don't know. So we start putting things in one at a time, and the first thing I do is try to just decrease the inflammatory response. So mast cell activation, we gave her antihistamines, ketotifen, and oral cromolyn, all the above eventually, and the pruritus and the rashes resolved. So, okay, so we know that there was some mast cell activation, and at least some of that was manifesting dermatologically. Black seed oil, Nigella sativa. Some kids find this very helpful in terms of decreasing neuroinflammation and some of the neuropsych symptoms. I don't think it did that much for her. She had a lot of neuropathic pain. Remember her leg pain that wouldn't, she refused to walk. So she's getting 10 milligrams sublingual BID. That really helped her leg pain. We put her on itraconazole, and she tolerated this without a problem. What we're doing is we're basically trying to kill mold or fungal colonization endogenously, because she has been exposed to mold when she lived back in the Southeast. She lives in the greater Denver area now. Cholestyramine, of course, as a toxin binder and methylation support. So methylfolate, methyl B12, SAMe, glutathione. You got to be careful with every one of these things, really, and particularly the methylation support. You accelerate methylation too quickly. You're going to start dumping a lot of toxins from inside the cells into the serum faster than the body can excrete it. Okay, so IVIG gets restarted. and incrementally increased up to the 2 grams per kilogram. Well tolerated, although in her, unclear benefit. Certainly other kids, we see pretty clear benefit, but it wasn't clear in Lindy. We put her on nystatin and probiotics and then antibiotics. So the first antibiotic was intravenous. Remember, this kid's not really taking orally. So we put her on ceftazidime, which is not really too dissimilar from ceftriaxone, and there was some mild improvement. Then we started her on Malarone. Again, mild improvement. Then we added daptomycin, significant improvement. I say really significant because then she starts eating and we can take out the hyperalimentation. She starts walking. She's happy. So daptomycin was a game changer. Daptomycin, as you probably know, is an intracellular antibiotic, and the bugs that were implicating, including the Mycoplasma, the Bartonella, and the Borrelia burgdorferi, the Lyme pathogen, these are mainly intracellular infections. And as you may be aware, daptomycin is one of the drugs in the 3-drug cocktail that the Zong protocol or study back in around 2020, when they said, we found this 3-drug cocktail that eliminates Lyme persisters, and it was ceftriaxone, daptomycin, and minocycline. So that was a game changer when we added the daptomycin. Okay, so you want to know what happened. Basically, she was doing quite well at that point, and I was fired. Now, I wasn't unhappy to be fired. It was a little challenging. This kid was amazingly manipulative, and she was making the best of it. That is, every day they would take her to Target where she could pick out a toy. That was to make her happy and not complaining and not grouchy. That would be the kind word to use it. And she was trying to dictate to me how much antibiotics she could get. And I said to the mother, look, I don't want to talk to your kid about this. I'm not going to be taking directions from an 8-year-old. And basically I got fired. Fine. But I'm still in touch with the mother on and off. The kid's doing very well. Okay. Case number 3, Maddie. So I initially saw her when she was 14, but complaints began at 8 years old, anxiety and panic attacks, then depression with these dark intrusive thoughts. These intrusive thoughts, it's really common in this population. And often it's, I want to kill myself, or I want to kill my siblings or my parents. I want to take a knife. These are what the thoughts are like. OCD, agoraphobia. She was not leaving the house. I mean, the first time I saw her when she came to the office, it was quite the challenge. Constipation, enuresis, syncopal episodes, palpitations, sleep problems, joint pains, drenching night sweats, chest pain, air hunger, muscle cramps, fatigue, sound sensitivity, numbness and paresthesias, constipation, bloating. Okay, this is typical of all my patients, quite frankly. It's not just a few neuropsychiatric patients, neuropsychiatric symptoms. And she was aware. She was aware that dairy caused her constipation. If you see constipation in a kid, take out dairy. More often than not, that's going to cure it. Sugar, she knew sugar caused panic attacks, and she couldn't stay away from sugar. Cravings were too strong. She had been put on gabapentin by her psychiatrist, and that did decrease the panic attacks, and mirtazapine, aka Remeron, that helps sleep. This also has antihistaminic activity. And fluoxetine, no good. As you all know, you have to be careful with SSRIs, particularly in this population group. Okay, so on physical exam, she was overweight. She clearly had POTS. She also had thrush with candid overgrowth on her tongue, dermatographia, prominent stria on her legs, arms, and breasts, and memory loss. She just, asked her questions. She said, I don't know. Okay. Here is a picture of her arm. I thought that was pretty impressive. Here's a picture of the back of her legs. Okay, so this kid had a lot of stria. These stria are really virtually pathognomonic for Bartonella. Bartonella Among other things, what it does is it stimulates a cytokine called VEGF, vascular endothelial growth factor. And what we're seeing on the skin is increased blood vessel formation. And it's in a different plane of the dermis than stretch marks, often confused with stretch marks, even though when you look at this, you say, geez, this isn't stretch marks. And in different planes than stretch marks. Here's laboratory. Okay, she had a slam dunk immunoblot IgM for Lyme. And, you know, I just want to mention something about IgM. If you Wikipedia IgM, I'm sure all you know that classically it's detectable within a couple weeks, but it tends to go down at 4 weeks and IgG takes over. That is not what happens with Lyme. And it's not what happens with some other microbial infections as well. I can tell you that my practice is mainly seeing people with chronic Lyme. So most of them have been sick for years or decades. And unless they've been treated, almost all of them, the vast majority of them have IgM positivity disproportionate to the IgG. This is really important interpretation because when they go to see the infectious disease physician, who usually won't let anyone in the doors with the diagnosis of Lyme anyway, that they say, well, you have IgM positivity, but you've been sick for years, is clearly a false positive. I have had many patients being told that. Not true. There's good documentation in the literature that IgM positivity is also consistent with persistent infection. Okay, so she's got Lyme. She's got a borderline antibody level to Bartonella, but there you go. Unfortunately, Bartonella, the serologies, the FISH, the PCRs, they're important to look for, but I can also tell you that while the testing is getting better, particularly at IGeneX and Galaxy Labs, it's better, but it's still not good. So we more often than not, make the diagnosis clinically, and in Maddie, it's pretty obvious. She tested negative for Babesia, but remember those night sweats? It's drenching night sweats. Almost certainly she has Babesia. So I would say the serological testing for Lyme is pretty good. Bartonella and Babesia getting better, but I can't say good. Okay, so she has negative strep antibodies. I'll just mention that the anti-DNase antibody tends to be more sensitive than the anti-streptolysin O antibody. She has some hypothyroidism, and you know, this is interesting. She's got normal free T4, normal free T3, but an elevation in TSH. And the standard endocrinologist or family doctor will say, well, this is subclinical hypothyroidism because her T4 and T3 are normal. I can't tell you how much I disagree with this subclinical business, because if you start talking to these people, they do have symptoms. And in fact, there's been studies done that show a TSH of 2.5 or greater shows some decrease in myocardial function. So again, Maddie has one MTHFR mutation. Her homocysteine is on the low side. This is the same pattern that I described in Lindy. Her fasting insulin was really up there. And that was enough to keep her blood sugars normal. But as you know, she's marching in the wrong direction in terms of getting diabetes. But, you know, elevated insulin levels, guess what? Of course, we know they not only lead to more obesity and increased risk of cardiovascular disease and then diabetes, but they increase inflammation. So we really want to deal with that. She also has elevation in urinary ochratoxins. We did a SIBO test because of her GI symptoms. That was negative. So what's her diagnosis? Well, she's got the trifecta, Lyme, Bartonella, Babesia. She clearly has autoimmune encephalitis, but I'm not calling it PANDAS because it didn't start with the abrupt onset of OCD or an eating disorder. But so what? You know, we can call it a PANDAS-like syndrome, but she's clearly got autoimmune encephalitis. And this is upsetting because I can tell you I have families who've gone to the neurologist and the infectious disease doctor or the family doctor, some of them say, oh, I don't believe in PANDAS. Whoa, it's like faith-based business. I don't understand that one. But they'll also say, well, this wasn't the abrupt onset of OCD or food restriction, and therefore it's not PANDAS. Well, okay, it doesn't fit that case definition, but it is autoimmune encephalitis. Okay, so she's got POTS. She's got food sensitivities clearly to dairy and yeast. And as you folks probably know, sugar stimulates yeast, and sugar gives her panic attacks, but she can't stay away from sugar. She's clearly got mast cell activation issues. She has hypothyroidism, the obesity and with insulin resistance, the methylation issues, and mold toxins. Okay. This is what's going on with the kids. It's not just one thing. There's all sorts of disruption in our regulatory systems, right? Immune, neuro, endocrine, which are not really separate systems at all. They're all working together. Okay, so what do we do for her? Well, we start by doing our best to eliminate dairy, sugar, and yeast. Unfortunately, those sugar cravings persist. Now, you'd think that this kid with agoraphobia who's home all the time, it wouldn't be that hard to deal with it because he just gets sugar out of the house. Unfortunately, her mother also has sugar cravings. I've talked with them multiple times about it. I said, you got to get the sugar out of the house, but no, mother's not going there. I suspect, without confronting the mother, that she needs that sugar to push down some real trauma, right? That's what we do with addictions. At any rate, we did the usual things. She was on chromium, which can help with sugar cravings. But she knew that if she had sugar, she would have a panic attack. We did give her nystatin and clotrimazole troches. The clotrimazole troches, I think, as you know, that's to treat the thrush. The nystatin oral, just remind you, the nystatin oral, it works in the gut. It is not absorbed at normal doses. So, it's just hitting what's on the mucosal surfaces. Armor thyroid clearly helped her energy. And we started her on disulfiram, and this is a few years ago, and I don't remember why we started on disulfiram, but it worked. We started her on 32.5 milligrams, right? As you folks know, it comes in 250 milligrams. This is like an eighth of a tablet. An eighth of a tablet every 3 days. This is 160 pounds, right? And for those of you who don't know, when disulfiram was approved, this was around 1950, and they were giving it to alcoholics. They were using 1,000 to 2,000 milligrams a day. We thought we were pretty safe with disulfiram. It turns out that alcoholics tolerate this drug a lot better than people with tick-borne infections. So we started her on a low dose and slowly progressed it, and she got much better, except for the anxiety. So all those physical symptoms, right? There was well over a dozen of them. They all got better. And then we slowly progressed from 2.5 daily to twice daily. And when she got to the twice daily dose, everything got worse again. And so we backed off to just 62.5 daily. And again, basically, all the symptoms were better except for the anxiety. And the anxiety means she's still agoraphobic. Okay. We tried her on L-A-bacillin. I'm going to talk about this later. This is something that Dr. Ami Katz has been recommending. It did not work for her. Just she wasn't better. She wasn't worse. And I put her on fluconazole, because of this ongoing sugar yeast issue. At 25 milligrams twice a week, major hercs. As you all know, this is a low dose. It's a really low dose for someone who weighs 160 pounds. And her weight was going up, by the way. We had to go down to 5 milligrams a day. So the point here is that yeast, in her case, yeast was triggering a lot of her autoimmune problems, including the autoimmune encephalitis. Okay, so what else? She was taking lorazepam as needed for the panic attacks. She was on the nystatin. For anti-inflammatories, the CBD was really helping. Gabapentin, I mentioned already, was helping. For mast cell, we had her on Cromolyn, ketotifen, and cetirizine. And what else? Well, we're treating her insulin resistance metformin and chromium. We're treating her methylation issues with Methylguard Plus. That's just the thorn variety that has 5-MTHF, but also has other B vitamins in it, methyl B12, et cetera. Methionine and SAMI. For anti-inflammatories, we are giving her Nigella sativa, Boswellia, omega-3s, alpha-lipoic acid for neuropathic issues. And also, when any patient I have on disulfiram, I have them on alpha-lipoic acid because neuropathy is a major potential side effect. Theanine and ashwagandha as calming influences, and magnesium as well, Dulcolax. Okay, so go back. The bottom line is she got much better. I mean, she was no longer agoraphobic, and she actually got her GED because she hadn't been going to school, but she got her GED, and she was working 2 part-time jobs, and her symptoms were sort of gone, except for in the premenstrual phase of her cycle, when particularly the anxiety would get worse. And so that's where we were when I wrote this up. Okay, so let's talk about diagnostic testing. And before we get to specifics, I want to point out, I want to question, does Lyme cause PANS? So I think we all know patients with neuropsychiatric Lyme disease share many symptoms with PANS patients, a lot of neuropsychiatric symptoms in both groups. So, and we know that we see PANS-like symptoms in people with Lyme. Okay, further evidence. Outer surface protein A, which is band 31. That antibody is responsible, I should say that antigen is responsible for triggering autoimmune inflammation, and it shares a protein sequence with strep pyogenes M5 protein. So this looks like, whoa, we're making a good case that Lyme can do this. And there's a whole bunch of studies that B. burgdorferi triggers autoimmune encephalitis. And now I'm going to put the brakes on a bit. There's no rigorous analysis for the presence of co-infection. All these studies, when you see these studies of here's what Lyme can do, there's not a breakdown of what the co-infections can do. And it's also understandable because the tests for the major co-infections, Bartonella and Babesia, they still suck. Okay. Meanwhile, co-infections are the rule, not the exception. I do not see people with just Lyme. Everyone has 2, 3, or 4. I've seen up to 6 tick-borne infections. So if people have multiple infections, how do you implicate any one microbe? Or is it the combination of microbes? What has been documented in the literature is Bartonella and Mycoplasma, 2 common co-infections, have been identified as triggering PANS. And I'll just say my clinical experience, and I think this is true for most of my colleagues, Bartonella is the worst offender. It causes so much inflammation and is really challenging to treat. So whenever I see anyone with tick-borne infections and significant neuropsychiatric symptoms, I'm thinking probably Bartonella. But because of these caveats, I don't think we'll ever be able to determine clinically if Borrelia burgdorferi or Babesia, for that matter, trigger PANS, because we're always seeing them in combination in any given patient. Okay, be that as it may, what do we want to do? Well, microbiology, we want to look for evidence of strep infection, anti-DNase B. I mentioned it's really a more sensitive tool than the ASO. We look for tick-borne infections, and I'm not talking about Quest or LabCorp. Really consider going to a very good lab. I think, personally, I use IGeneX, but I think that Galaxy is also a good lab. They're not the only ones. They're the ones I have most experience with. Mycoplasma pneumonia, you can use the traditional labs for this, but make sure they're doing a quantitative, not a qualitative assay. Epstein-Barr, we're seeing, oh my God, we're seeing huge amounts of Epstein-Barr activation, particularly because of COVID. And Epstein-Barr can cause these problems. If the, most people have IgG positivity to the normal antigens, but the early antigen IgG we see in both in acute Epstein-Barr, as in mononucleosis, but also in reactivation. And then there are other herpes viruses, there's Coxsackie and so on. Okay. And you should certainly want to measure quantitative immunoglobulins, including IgG subsets, antineuronal antibodies, and there's the Cunningham Panel, which Craig has elucidated, and the GAD65, really important test because it is an entryway to getting IVIG. You can check histamine levels, but I do think mast cell activation is more a clinical diagnosis. It's great if you can see an elevated histamine level or tryptase levels. There's a bunch of tests you can do. We've talked about methylation testing. Allergy testing. Well, you can do IgE and IgG food allergy testing. You can also test for sensitivities to fungal species, test for urinary mycotoxins. Even kids, I see having problems with their adrenal glands, that they're so stressed out that they have some adrenal insufficiency because their adrenals have been on overdrive for long enough that they've lost reserve. Thyroid hormones, antibodies. So that's a standard workup for these kids, okay? And now let's talk about treatment. There's 3 major interventions for these kids. So one is treat the symptoms with psychotropic medication. I mean, these kids are in hell, really, between the anxiety, the depression, and the psychosis. This is hell, and the family's in hell too, quite frankly. So psychotropic medication and or supplements, whatever works. Anti-inflammatory interventions and antimicrobials. Okay, this is the 3 things that are obvious, most important. So let's talk about the psychotropic medications and or supplements. Okay, SSRIs are used a lot, but have to be done very carefully. We know that some of these kids can actually become suicidal or have other bad reactions, often just don't respond at all. Antipsychotics can be very helpful. And I just want to remind you that these kids with inflammation in their brains, that they may have really bad reactions to any of these psychotropic drugs or not respond to them at all. Gabapentin can be very helpful. I've seen that. And then there's over-the-counter stuff, theanine, GABA, these are hit GABA receptors, magnesium, CBD, ashwagandha. These all can be calming. And some things work in some people, some things work in other people. I just put them in one at a time and see what works. Doesn't work, we go to the next one. Okay, what are the anti-inflammatory interventions? I didn't mention everything you can do here, but IVIG is the most prominent. If you can get it approved, as far as I know, Illinois is the only state where it's mandated that insurance carriers cover this for any kid with a diagnosis of PANS. Hopefully that's going to spread, but do your best, because in some kids it's a deal changer. Okay, so, and there's just a recent study just came out, I don't know, the end of last year, maybe, I think. So there's a few studies out there showing improvement with IVIG. What I haven't put down here is steroids. I think there is a place for these steroids, but not as a first-line treatment. I wouldn't put a kid on steroids unless they were already on antibiotics, because I really wouldn't want to flare the infections. Interesting that some of the kids do better with NSAIDs, ibuprofen being the most common. I have a kid who's actually doing better on Celebrex. These are anti-inflammatories, right? Nigella sativa, I already mentioned. And then, here are things that we use frequently for inflammation, whether it's in the brain or otherwise. Curcumin, boswellia, CBD, essential fatty acids, omega-3s in particular. NAD, I have a patient in whom I didn't even know this until the patient got this from a local naturopath. She was getting intravenous NAD, and it really helped her OCD. And then she was taking it sub-Q herself, really helped her OCD. So it also has anti-neuroinflammatory action, low-dose naltrexone. I have to say, I'm really unimpressed with low-dose naltrexone. I know on paper it looks really good. It, among other things, decreases interleukin-2. But I just rarely see kids or adults, for that matter, respond to low doses naltrexone. I am wondering whether full dose naltrexone can help. There are case reports of full dose naltrexone helping OCD, and I have a patient who's done well on that. Okay, antimicrobials. So, really first, I like to see these kids on some control of their neuropsych symptoms with the psychotropics, and we do what we can to decrease inflammation, because then they're more likely to tolerate the antimicrobials, because it's so easy to herx these kids and make their life go from hell to even worse. So it's important to start slowly and progress gradually. I specialize in tick-borne infections, right? So they all have Lyme, even if that's not the major pathogen here, who knows? But I'll usually start to go after that first. And it's not just Lyme, but with all these bugs, we're trying to hit both intracellular and extracellular microbes. And if the kids are really sick, I go to IVs. And you saw with Lindy, she did a turnaround when we added the daptomycin to the ceftazidime. I really like that combination, but who knows? The next patient may not respond to that particular combination. Meanwhile, Dr. Ami Katz, he's a colleague and neurologist in Southern Connecticut. He's really big on LA bacillin. And I've seen it work. And I've talked with him lots of times. We don't know why it works. For one thing, we're not using very high doses. If I was treating just plain old Lyme disease with LA bacillin in an adult, I'd be giving 2.4 million units a couple times a week. Okay, we're talking 1.2 million units IM weekly, not a high dose. And in some kids, it's very effective. And I would say in my clinical experience, maybe 50% of kids get a significant improvement from this dose. You can see that if a kid is less than 100 pounds, we use a lower dose. And we give them 10 weeks. If they don't have any response in 10 weeks, then we stop the LA bacillin. It's important to give biofilm busters to these kids. Remember, they can herx on those as well. But all these chronic infections are associated with biofilm communities. Okay, but what else is going on? Well, here we go. Mast cell activation, really common. Dysautonomia problems, and which also, by the way, can be triggering the anxiety. Those two, dysautonomia and mast cell activation, they go hand in hand. You see one, you usually have the other. And that includes sleep disorders. Dysautonomia is associated with central sleep apnea. But these kids often can't sleep. And, probably my first line for that is giving them Benadryl. Okay, sensitivity syndromes, foods, and these kids have been sick for a while. They have a lot of inflammation in their body and they become sensitive to a lot of stuff. I've listed the most common foods that I've witnessed these kids are sensitive to: gluten, dairy, eggs, yeast, and corn. They can be sensitive to anything. There is testing, IgE and IgG testing for food sensitivities. The testing is false positive and false negative. You can't rely 100%, but if you can test 200 things at once, it can give you some clues. Mold sensitivity, again, these kids mostly did not have mold sensitivity before they developed this autoimmune systemic inflammation. And now they become sensitive to a whole lot of things. It's not unusual that I'll have a kid living with a family in a moldy house. It's only the kid who's infected who's having problems with the mold. methylation mutations, mold toxins, endocrine disorders. All of these things need attention. And this just is, a visual, the beaker metaphor. There's a lot of things that add up and lead to illness. Beaker metaphor is used a lot for environmental illness, folks. Okay, I'm going to digress a little bit, or maybe go on a tangent. So autoimmune encephalitis, do not be limited by the case definition criteria of PANDAS. Okay, I actually really don't like the PANDAS nomenclature. It's not just pediatric, it's not just acute onset. So there it is. Not just pediatric, not just acute onset. And it's not just OCD with or without anorexia and other mood and behavioral issues. In other words, it doesn't have to fit the case definition. It can manifest as major depressive disorder or just anxiety and panic attacks. And how do you know? Well, you look for, is there an underlying microbial illness? Do they have a positive Cunningham panel? I'll just mention, we did a case series. There's up in Estes Park, which is the foothills of the Rockies, there is a adolescent residential treatment center, and these kids are all diagnosed with DSM-5, major depressive disorder, most of them also with anxiety disorders, no known organic issues with the exception of one kid who has celiac. And they can't hack it at home, they can't go to school, they're just, but this is a good facility. And we tested 10 of them. Out of those 10, 3 of them had strep antibodies. 6 of them had definite antibodies to tick-borne infections. Depending on how you interpret that, it could be up to 9. 9 out of 10 of these kids diagnosed with MDD had flagrantly positive Cunningham panels. Thank you to Molecular Labs for doing that for us. And it stunned us. It just stunned us how common autoimmune encephalitis may be in our patients with mental health disorders. So tick-borne microbes often cause autoimmune encephalitis with neuropsychiatric symptoms. I think you know that. We talked about it in the last presentation, but besides those tick-borne microbes, multiple other microbes, some of which I'd listed. And then food sensitivities and mold can also trigger this, but particularly if they already have autoimmunity and systemic and neuroinflammation caused by the microbes. That's when you see these kids also developing food sensitivities and mold sensitivity, usually. But they may be atopic from birth, just from a genetic profile. Okay, you've seen this before, psychiatric conditions associated with Lyme disease. Well, guess what? It looks a lot like kids with PANDAS, right? And then psychiatric conditions associated with Bartonella infection. Again, you've seen this before. And again, Bartonella, the worst offender. Mycoplasma, we think of this as mainly a respiratory infection, but besides PANS, it's been shown to cause acute psychosis, OCD, mania, and eating disorders. All of that sounds a lot like PANS, doesn't it? And then I just want to point out, this came out 2 weeks ago by our colleagues, Bob Bransfield, Mao, and Greenberg, Rosalie Greenberg, basically documenting, it's not just tick-borne infections. You can see all these different pathogens associated with mental health disorders. So check it out. This is truly an encyclopedic article. Okay, and I want to point out that there's a huge amount of data now that neuroinflammation is associated with mental health disorders, or I should say it the other way around. Mental health disorders are associated with neuroinflammation. And here I've listed and given you studies you can check out. One of the things that I want to mention is that when you read these studies, they talk a lot about bidirectionality. That is, the mental health disorders cause inflammation, and the inflammation causes mental health disorders. That word bidirectionality is used a lot. And, okay, this is a schematic that I made for a paper that has yet to be published. And I just want to point out, if I find it, okay, right here. So we've been talking about inflammation, infection generating inflammation, and that can cause autoimmunity and mental illness. But I want to point out stress and trauma. Think of kids with PTSD and adverse childhood experiences. Those kids have also, there's a lot of evidence that, they don't have just autonomic dysfunction. They have a ton of inflammation. And then probably that inflammation feeds back into the limbic system and generating, a whole lot of psychological symptoms. I could take an hour just reviewing the implications of this slide. But I want to leave you with the fact that stress and trauma can also start to generate autoimmune encephalitis. And if you add, people with PTSD and significant adverse childhood experiences, and then you get a Lyme infection and mold exposure on top of that, you got major inflammatory responses and, frankly, a living hell. So that's what I'm going to leave you with. This is a quote from Oliver Wendell Holmes. And I want to point out that Oliver Wendell Holmes, we all know, is a poet. But guess what? He was also a physician. And in the mid-1800s, he pointed out that women who were dying of childbed fever, right? It was basically after they delivered babies, they became septic, and a lot of them died. A real lot of them died. And he pointed out this didn't happen with midwives, where the women got delivered at home, but it did happen in the hospitals, where doctors are going from one person to the next, not washing their hands. The midwives just intuitively knew to wash their hands. This was before the discovery of microbial pathogens. At any rate, no one listened to him, but he was looking at something from a new perspective. And this is a quote from Oliver Wendell Holmes: "A mind that is stretched to a new idea never returns to its original dimension." And the idea here is that it's not just that stress psychosomatically can affect our bodies, it's that our bodies, and inflammation in particular, can result in mental illness. It's both directions. It's bidirectional. Okay, folks, that's it. That's my book, which goes into a lot of this in a lot more detail. And we're done. I'm open to questions. So thank you very much for your kind attention.
Thank you, Dr. Kinderlehrer. That was an excellent talk. I could listen to you talk all day and always learn something new. I appreciate that. We do have a couple of questions, a few questions, and a couple that I can just, there are technical questions that I can reply to directly. Everyone who has registered for this webinar will receive a copy of the webinar within about 3 days, given that there's a weekend involved. We get that turned around as quickly as possible, and we will send that out to all of our registrants. So you'll be looking for that, and if you don't receive it, by all means, let us know. The first question here is, can you recommend some reliable testing for MCAS and describe the core clinical manifestations?
I'm sorry, for what condition? For
MCAS. MCASS.
Yeah. I mostly diagnose mast cell activation syndrome clinically. The first thing I do on exam is I check for dermatographia. And again, that's when we basically have scratched the forearm on the hairless side of the forearm and see if they have excess histamine. I will draw histamine levels. I've also drawn tryptase levels, and sometimes they're elevated and sometimes they're not. There's more testing that can be done, but mostly I see whether they respond to treatment. Like Lindy, the second patient, she had itching and rashes, and when we put her on some mast cell stabilizers and antihistamines, it went away. I can tell you that mast cell activation syndrome is really common in this setting.
Okay. Another participant says, thank you, Dr. Kinderlehrer. What kind of tests have you run on CSF? And have you ever used MNGS to look for microbes?
Well, I don't recommend these kids get spinal taps. You know, unless we're thinking they actually have an infection in the brain, and there's really not an indication for a spinal tap. The kids with autoimmune encephalitis generally have normal spinal taps. So I'm not looking for anything. If I was going to do it, I would, look for antibodies to Lyme and so on. But I'd only expect to see that in people with Lyme meningitis, which is really separate from autoimmune encephalitis. And the test you mentioned is not one that I'm familiar with.
Nor am I. I apologize for that. Dr. Shimasaki, if you're still on with us, perhaps you could let us know what that means. And even if I can answer that offline, I'd be happy to do that. Dr. Shimasaki, there's a question for you. Dr. Shimasaki, we have an 18-year-old patient who was quite suicidal with serious brain fog due to PASD and ADHD. His Cunningham Panel was positive, as was Lyme screening. He had gut dysbiosis and gluten sensitivity. He refused antibiotics for Lyme and refused IVIG. He was treated with Celebrex, melatonin, a gut healing protocol, and a gluten and dairy-free diet. He dramatically improved. Can you help us understand the possible immunologic underpinnings of his improvement?
Yeah, that's a really great question. Let me add also that I know that we are over. Thank you, those that can stay on. It will be recorded. And Dr. Kinderlehrer, I think we might even ask you to have a microbes and mental illness 3, where there's a lot of just questions and answers. But this is a great question and an illustration of how holistically the body functions, in that there is more than just one answer to all of this. The treatments obviously look like they were more related to a little bit of anti-inflammatory and gut healing. The endothelial lining in the gut is a very similar endothelial lining to the blood-brain barrier. Also, the tight junctions in the places in which these opening and closings occur. And you've heard of the phrase leaky gut, leaky brain. One of the things that we are researching here is that we are looking at different blood-brain barrier integrity markers as a surrogate to aid in which these might be influencing the actual manifestation of these symptoms, because we're looking at serum autoantibodies. And what it is important is, I would guess that this patient's autoimmune antibody panel would still be positive, though they may be improved. Because none of these treatments actually had anything really to deal with the offending microbe or the presence of these antibodies. So one of the things that is important to see is it does take an insult, it does take inflammation and these autoimmune antibodies, as well as a blood-brain barrier permeability. And so it is good to know that these are alternative types of treatment, but there might be an important thing in Dr. Care. We would love to be looking at this as a potential case study to follow the patient and looking at their serum autoantibodies and whether or not the patient might relapse. So that's one potential explanation.
Thank you, Dr. Shimasaki. The response to the MNGS is It's a broad approach that looks for DNA or RNA of microbes, metagenomic next-gen sequencing. Any comment from either of you?
I have not had experience using that profile.
Something to keep in mind. The last question we have is, how long did you wait between, this is regarding your patient, Lindy, how long did you wait between starting mold treatment and then starting antibiotic treatment for Lindy?
I have to think back now. Not very long, because she tolerated the mold treatment well, but was not improving on the mold treatment. So it was probably a couple of weeks that she was on, you know, the itraconazole and so on, before, and the toxin binders before we started the antibiotics.
Do you have a preferred test for mycotoxin or mold infection?
That's a really good question. You know, molds can cause problems a lot of different ways. It seems like if we're exposed to mold and our immune system's intact, it's no big deal, right? When I say intact, I mean not that it can kill things, but that it's also secure and doesn't need to overreact to things. So, you know, stable immune system, and it can say this antigen is not a threat to me. I don't need to react. Okay. But once a person's in an inflammatory state, they're more likely to become reactive. And one first thing to do is check where they live. You know, is a mold exposure ongoing? The next thing, though, is to look at, do they have endogenous mold issues? And, you know, we don't have a way of measuring mold inside them, but we can measure mold toxins in their urine, which is not the same as measuring mold toxins in their body. So what's happening is that that they can be sensitive to the mold inside them, and that's another potential autoimmune inflammatory process. And I can see the same symptoms from mold sensitivity that we do to these tick-borne infections or other pathogen infections. Sometimes the mold problem is the worst problem. You know, with the third patient, Maddie, I really believe that at least it became her worst problem. She sort of stabilized on the disulfiram to treat tick-borne infections. But boy, you know, the sugar, the yeast, you know, I think also mold, you know, I think that's hugely problematic. So you have that as a potential inducer of inflammation. The mold toxins can do two things. One is it can make it more difficult to treat the infections, because guess what? These mold toxins can undermine immune function, but they can also cause a lot of symptoms, particularly neurologically, and you could actually be sensitive to the mold toxins. So there's multiple ways that these mold exposures can be problematic in someone who becomes sensitized. And I don't know if I answered the question or not.
I want to thank you very much for round 2 of microbes and mental illness. I'm looking forward to round 3. And I want to thank all of our participants. Again, a copy of the recording will be sent to you within a few days. Dr. Shimasaki, thank you very much. Dr. Kinderlehrer, thank you. Everybody keep warm, and we'll see you next time.